Imagine this. You're, walking along, maybe a little distracted, and suddenly, bam, you trip, you fall, and that first thought that flashes through your mind isn't about your knee or your elbow. It's about your tooth. Is it chipped? Is it loose? Is it gone? That immediate jolt of panic around a dental injury is something I think many of us can probably relate to. Well, today we're taking a deep dive into exactly that, the intricate management of alveolar and dental fractures. We've got a stack of specialized sources, articles, and some really cutting-edge research. Our mission is basically to pull out the most crucial nuggets of knowledge, giving you a clear, concise understanding of what happens when teeth and, well, their supporting structures get injured. Everything from surprisingly sophisticated historical treatments all the way up to the absolute cutting-edge modern protocols. Our goal is for you to walk away from this well-informed and maybe even surprised by some of the details. Okay, let's unpack this. When we talk about dental alveolar trauma, we're just, talking about injuries to your teeth and the bone that holds them in place. And what's truly remarkable, I think, is that this kind of injury is as old as humanity itself. So before modern dentistry, like before x-rays and fancy drills and all that, what did people actually do about a knocked out or a fractured tooth?
Yeah, it's actually fascinating how early people began to grasp these injuries, even without our modern tech. We're talking ancient times. Take Hippocrates, for example. Living, over 2 millennia ago?
Yeah.
Around 350 BC to AD 750, somewhere in there.
Yeah.
He was already discussing binding teeth together in mandible, jaw fractures. He used materials like gold wire or linen thread, essentially creating what he called a bridle wire, a very, very early form of dental splints. But here's the really interesting part. He stressed recapturing the proper occlusion, how your teeth meet, is absolutely essential for healing. And that's a concept that's still critical today. You could argue he was one of the first to see the value in, what we now call evidence-based treatment.
Wow, that far back, using gold wire.
Right. And it wasn't just him. Archigenes, around the 1st century BC, he even proposed a sort of medieval endodontic procedure using a hot iron instrument inside the tooth to cauterize the pulp. Pretty intense stuff. Then Claudius Galen, a bit later, he also emphasized getting that occlusion right for fractures. And we even have actual physical proofs. There's a 500 BC mandible found in Lebanon that clearly shows gold wire used to splint periodontally involved front teeth.
That's incredible. So even without all our modern tools, they understood fundamentals like the bite. It really shows that drive to heal has been around forever, long before evidence-based was even a phrase. When I hear dental injury, I kind of automatically picture maybe a sports accident or a kid falling. But looking at these sources, it seems the who and why are actually, a lot more diverse and frankly quite surprising. What did you find in the data about who gets these injuries and how?
It's true. The causes are really highly age-dependent, and they show some interesting demographic trends. So in the pediatric population, the #1 cause is almost always falls, especially in those really early years, right? Think about it. Young kids, they have poor coordination. Their skeletal weight distribution is still developing. They're often kind of top-heavy. Studies show these injuries affect roughly 11% to 30% of kids with primary or baby teeth, and about 5% to 20% with permanent or mixed dentition.
Okay, that's quite a range.
Yeah, and we see 2 peak periods for these injuries.
Yeah.
Ages 2 to 4 years, and then again at 8 to 10 years. And boys are about twice as likely to experience them as girls. As kids get a bit older, into childhood and adolescence, about a third of all dental trauma comes from contact sports and playground activities. It's a big chunk, but thankfully the increased use of mouth guards and proper headgear has really helped cut down on those sport-related injuries, which is, it's a big win.
That's good news, at least.
Definitely. But then there's a truly concerning cause we have to talk about, and that's child abuse. It's an alarming statistic, but back in 2000, an estimated 879,000 children were abused in the U.S. alone, nearly 20% physically abused. And what's directly relevant here is that over 50% of physical trauma in child abuse cases happens in the head and neck region in the U.S.
Over half. Wow.
Yeah. And internationally, about 7% of all physical injuries involve the mouth, the oral cavity. That number jumps to 9% for kids and teens up to 19 years old. It's a stark reminder that sometimes an injury isn't just an accident,
Right. A really important point. And what about adults? How do the causes shift then?
So for adults, the picture changes. Injuries are typically due to things like motor vehicle collisions, contact sports still, physical altercations or assaults, industrial accidents, and also what we call iatrogenic injuries. That just means injuries caused unintentionally during medical or dental treatment itself.
Iatrogenic.
Okay. There are also significant psychosocial factors involved. Some research points to orofacial injuries from intentional violence, disproportionately affecting socially and economically disadvantaged minority populations. And there's a strong link between substance abuse, particularly alcohol and street drugs, and these kinds of injuries. Patients who test positive for drugs or alcohol when they come in with an injury often have a history of previous head or facial trauma, and unfortunately, a pretty high rate of it happening again.
A cycle, sort of.
Exactly. Other groups at higher risk include people with seizure disorders, certain mental disorders, and congenital maxillofacial abnormalities, and those iatrogenic injuries we mentioned. Tooth damage is actually the most frequent claim related to anesthesia. Often happens due to, well, poor technique during intubation, placing a breathing tube, or from the unmonitored biting force of a patient who's unconscious.
That makes sense. And are certain teeth more likely to get hurt than others?
Yeah, definitely. It's usually the maxillary incisors, your upper front teeth, especially if they protrude a bit, what dentists call a Class 2 Division 1 malocclusion. They're just often the first point of impact in direct trauma. Indirect trauma, like a hard blow to the chin that slams the lower jaw up, that can injure the back teeth, the posterior ones. And the type of injury varies too. In kids with baby teeth, it's usually different forms of luxation, where the tooth gets jarred or moved in the socket. That accounts for about 75% of cases. But in permanent teeth, crown fractures or crown root fractures are more common, making up around 39% of injuries.
So it's really not just random bad luck then. These injuries often tell a deeper story about age, activity, even societal issues. It turns a simple injury into, well, a lens for looking at public health trends. Quite eye-opening. Now, let's say you've just had an injury, maybe a significant one. Your gut reaction might be to focus right on that chipped or loose tooth. But I imagine for a clinician, the very first steps are much broader, right? What are the non-dental, maybe even life-threatening things they have to check first?
You've hit the absolute critical point there. Beyond the obvious dental injury, the first priority is always ruling out other potentially life-threatening issues. It starts with a really thorough history, getting crucial pre-injury info. Biographical details, medical history, exactly when and where it happened, any loss of consciousness, the precise nature of the incident, all that can really speed up getting the right treatment.
Okay, getting the backstory first.
Exactly. But the immediate concern is what's happening systemically inside the body. Clinicians absolutely have to check for potential aspiration, inhaling something into the lungs like airway compromise or any neurosensory deficits before they even think about touching the teeth. What we call occult head injuries, like hidden ones, basal skull fractures, epidural hematomas. They can happen even from a brief loss of consciousness less than an hour if there's facial trauma involved.
Occult meaning hidden.
Precisely. Hidden. And they're incredibly dangerous because they might not show obvious signs right away, but can have devastating outcomes if missed. You have to watch for subtle signs, like maybe confusion followed by these lucid intervals where the person seems okay for a bit, then declines again. And if teeth or fragments or even fillings are missing and unaccounted for, you have to suspect aspiration. Listening to the chest for wheezing or labored breathing is essential. The right main stem bronchus is a common spot for foreign bodies to end up. If needed, x-rays of the neck, chest, abdomen are used to confirm.
Right. Got to make sure nothing went down the wrong pipe.
Absolutely. Then the physical exam itself is very detailed. Preoperative photos are often taken partly for medical legal reasons. It's a systematic inspection, both outside and inside the mouth, checking soft tissues for cuts, scrapes, bruises. And importantly, if the injury doesn't quite match the story given, especially with children, women, or the elderly, there's a protocol to consider and rule out abuse.
That's that concerning factor again.
It is. Specific signs are key too, like bruising under the tongue, at the floor of the mouth that's considered pathognomonic, a really distinct sign for an underlying mandible fracture. Other signs include, gross mobility of teeth, bleeding around the gums, step defects you can feel in the bone, maybe a crunching sound or if the bite is suddenly off.
Okay, and imaging, x-rays.
Crucial. And you want to get initial x-rays before any manipulation inside the mouth, especially with kids, to avoid damaging those developing permanent tooth buds underneath. Common views are periapical, like a close-up of a few teeth occlusal showing the biting surfaces, and panoramic, which gives that wide view of both jaws. And yes, if teeth are missing and you can't find them, chest or abdominal films are definitely needed.
So much investigation before even focusing on the tooth. Then what about assessing the tooth itself?
Right, then we zoom in on the teeth. Looking for damage to the enamel, the dentin underneath, and checking if the nerve inside is involved. If a whole crown seems really mobile, that might indicate a crown root fracture going deeper. Then there's percussion testing, gently tapping the injured tooth and a healthy control tooth. A dull sound might suggest the tooth's been luxated, jarred in its socket, or maybe there's an alveolar fracture around it. An enamel fracture might sound a bit like a cracked teacup, whereas an uninjured tooth usually gives this solid metallic resonance. It's useful, but done very carefully. Don't want to add insult to injury, right?
Right, gentle tapping.
Exactly. Then pulp testing, using things like mechanical, thermal, or electrical stimuli to check the nerve conduction inside the tooth. This one's a bit controversial right after the injury, especially with kids because, well, cooperation can be an issue. Plus, you can get false negatives. The tooth might seem dead initially, but could actually reestablish its blood supply, revascularize within about a month.
So it might recover on its own.
Potentially, yes. And a key factor here is root development. If the root tip isn't fully formed yet, what we call open apiece in immature teeth, it's like having a wider pathway for blood supply, giving it a much better chance to heal itself. It's almost like a superpower for young teeth.
Okay.
For mature teeth with closed apices, fully formed roots, that healing potential is much lower. Newer tech, like laser Doppler flowmetry, LDF, looks really promising though. It can assess the pulp's vitality by actually monitoring blood flow, even when other tests might be negative.
That's a huge amount of detective work. So once all that's done and an injury is diagnosed, how do professionals actually categorize it? You mentioned it's like a secret language for communication, but also key for treatment, right?
Exactly. A standardized classification is absolutely vital, not just for clear communication, between dentists or specialists, but mainly for consistent and effective treatment planning. The Andreessen classification is the most widely used one, so much so it's been adopted by the World Health Organization. It's really comprehensive and works for both permanent and primary teeth.
Okay, Andreessen. What does it cover?
It breaks injuries down into several key categories. First, you look at injuries to the dental tissues and pulp. This covers everything from a subtle crown infraction. Think of that like a craze line in the enamel, a crack that hasn't quite gone through, to full crown fractures. These can involve just the enamel or both enamel and dentin, or go deeper and expose the pulp, the living tissue inside. It also covers crown root fractures and root fractures, which, go deeper into the tooth structure.
So damage to the tooth itself.
Right. Then, after assessing the tooth, you have to look at its foundation. That brings us to classifying injuries affecting the periodontal tissues. These are the ligaments and bone holding the tooth in place. This category ranges from a concussion, where the tooth is just sensitive to tapping, not loose or moved to a subluxation, where it's loosened but not actually displaced. More severely, you have luxation, which means the tooth is displaced from its socket. This could be lateral, pushed sideways, intrusive, pushed up into the bone, or extrusive, partially pulled out of the socket. And finally, the most severe is avulsion. That's when the tooth is completely knocked out, gone.
Okay, so concussion, subluxation, luxation, avulsion. Got it. What else?
The third category looks at injuries to the supporting bone. This can mean combination of the alveolar housing, where the bone around the tooth socket is basically crushed, or maybe a fracture of just a single wall of the socket, or a fracture of the alveolar process en bloc, meaning a whole segment of bone holding multiple teeth has moved together. It also includes larger fractures involving the main body of the jawbone, the mandible or maxilla.
So damage to the bone holding the teeth.
Exactly. And finally, the fourth category covers injuries to the gingival or oral mucosa, the soft tissues, gums, inside of the mouth. These can be an abrasion, like a scrape, a contusion, which is a bruise, or a laceration, a cut. This whole systematic approach ensures everyone involved understands the precise nature and extent of the injury right away.
That detailed classification makes so much sense for clear communication and planning. Okay, now for the really critical part, treatment. You mentioned it ranges from simple fixes to really complex stuff, all trying to save the tooth. It sounds like a real race against time sometimes, especially if a tooth is completely knocked out. What's the biggest challenge there?
You're absolutely right. The time sensitivity is a huge challenge, particularly for avulsed teeth, the ones not clean out. The precise, often time-sensitive nature of these treatments and how different injuries need really tailored approaches, that's what makes this field so fascinating and so vital. Every decision is aimed at giving that tooth the best possible shot at survival.
Okay, so walk us through some common treatments. What about those crown fractures?
Sure, let's start with crown fractures. If it's just the outer enamel chipped, treatment is usually pretty simple. Maybe smoothing the rough edges or repairing it with a tooth-colored composite resin. Easy fix, relatively speaking. If the fracture involves both enamel and the dentin underneath, but the pulp inside isn't exposed, and this is actually the most frequent injury type in permanent teeth, the main goal is protecting that pulp. We do that by sealing off the exposed dentin tubules, usually with the dental bonding agent, and then placing a composite restoration over it.
Okay, sealing it off. What if the pulp is exposed?
Right, for crown fractures with pulp involvement where that sensitive inner part is open to the mouth, the outcome really depends on a few factors. How much time has passed since the injury, how big the exposure is, the pulp's overall condition, and crucially, the stage of the tooth's root development, those open versus closed up pieces we talked about.
Time seems critical again.
It really is. The best chance for success is if it can be treated within the first 2 hours or so. For immature teeth, those with the open apieces, every effort is made to keep that pulp alive. We might do a direct pulp cap with calcium hydroxide for small exposures, or a pulpotomy for larger ones. Calcium hydroxide actually encourages the root to finish developing. For mature teeth, the ones with closed apieces, if there's extensive tooth loss, root canal therapy is often the necessary route.
Okay. What about fractures that go deeper into the root?
Good question. Root fractures are often diagonal and can be tricky to spot initially on x-rays. Sometimes it takes a week or two for inflammation to make the fracture line visible. If the fracture is in the apical or middle third of the root nearer the tip, they usually don't need splinting unless the tooth is really mobile. If it is, a rigid splint might be used for about 12 weeks. Fractures closer to the gum line in the cervical third, unfortunately, often mean the tooth needs to be extracted, where sometimes specialized orthodontic extrusion can save it.
Seems like the location of the root fracture matters a lot.
Definitely. Now, moving to periodontal tissue injuries or luxations, the big worry here is often root resorption, where the body starts dissolving the tooth root. For a concussion, where it's just sensitive to tapping, no looseness, treatment is usually just taking the tooth out of heavy biting contact and watching it closely. Maybe minor adjustments. A subluxation means it's loosened but not moved out of place. It's sensitive, maybe some bleeding at the gum line. Treatment is similar to concussion, maybe temporary non-rigid stabilization if it's very wobbly. This type actually has the lowest risk of resorption, which is good.
Okay, so concussion and subluxation are less severe. What about the others? Intrusion sounds bad.
Yeah, intrusive luxation, where the tooth is pushed into the bone, is one of the most severe, especially in kids. It has really high rates of pulp death necrosis, about 96%, and inflammatory resorption, around 52%.
Wow, those are high numbers.
They are. Treatment depends on root development. If the root is incomplete, we often just watch and allow it to naturally re-erupt, maybe over 3 months. Orthodontics might be needed later. If the root is fully developed, it requires carefully repositioning the tooth, a non-rigid splint, and starting root canal therapy, often with calcium hydroxide, maybe 10-14 days after the injury, to try and stop that resorption.
And extrusion, pulled out partly.
Extrusive luxation, yeah. That involves gently pushing it back into the socket, checking the bite, and using a non-rigid splint for maybe 2 to 3 weeks. About 64% of these end up needing root canals due to pulp necrosis. Lateral luxations are when the tooth is pushed sideways, often taking some of the socket bone with it. Treatment involves carefully moving the tooth and bone back to where they should be, then a non-rigid splint for 2 to 8 weeks, depending on bone healing. We try to avoid things like forceps to reposition it to minimize more damage.
Okay, that covers teeth getting knocked around. What about when they're knocked completely out? Avulsion, you said that's the worst.
Yes, exarticulations or avulsions, tooth completely out of the socket, are generally considered the absolute worst dentoalveolar injuries. The single most critical factor for success is the viability of the periodontal ligament, the PDL cells on the root surface. Think of your tooth root as being covered in these tiny living fibers that attach it to the bone. If those cells die, the tooth just won't reattach properly long term. That's why every minute counts when it's out of the mouth.
So what do you do with a knocked out tooth? Where do you put it?
Great question. Ideal storage solutions are things like Hank's Balanced Salt Solution HBSS or VSPAN, which is actually an organ transport medium. HBSS can keep those PDL cells alive for maybe 24 hours. VSPAN even up to a week. HBSS is what's in those Save-A-Tooth kits you can buy.
Okay, Save-A-Tooth kits. What if you don't have one?
Good point. For a layperson, the best temporary storage is milk. It won't necessarily replenish the cells, but it can help prevent further cell death for a short time. It's most effective if the tooth has been out for less than 20 minutes and kind of loses its effectiveness after about 6 hours. Saliva, like keeping it in the person's cheek if they're conscious and old enough not to swallow it, or saline solution, are also temporary options.
Yeah.
Water is generally not recommended as it can damage the cells.
Milk is surprising, so get it back in the socket ASAP.
ASCP is the key. Immediate replantation, getting it back in within the first 2 hours, is optimal. After about 2 hours, those vital PDL cells become irreversibly necrotic, dead. But we always attempt salvage even if it's been longer, though the prognosis definitely gets worse.
So what's the treatment protocol look like then?
It's quite detailed and depends on root development and time. But basically, for teeth with open apices, replanted within 2 hours. Usually into HBSS for 30 minutes, maybe an antibiotic rinse, then immediately replanted and splitted for about 7 to 10 days. If problems arise later, we might do apexification to encourage the root end to close, using calcium hydroxide or maybe a newer material like ProRoot MTA.
And for closed apices, mature teeth.
Similar initial steps if within 2 hours, HBSS for 30 means, replant splint for 7-10 days. The big difference is that root canal cleaning and shaping are usually done before the splint comes off, and a calcium hydroxide filling is often left inside for maybe 6 to 12 months to help healing and fight resorption. If the tooth has been out for more than 2 hours, the root apex status matters less. The dead PEL is often removed, maybe with sodium hypochlorite, an external root canal is done, and then the root surface gets specific chemical treatments like citric acid, stannous fluoride, doxycycline before final filling and replantation. It's really trying to prepare the surface for a different kind of healing then.
That's incredibly specific. And you mentioned splinting several times. What exactly is that?
Right, splinting. The basic idea is to immobilize the injured tooth or teeth to allow healing. For luxations and avulsions, it's mainly for pulpal revascularization and PDL healing. For root fractures, it's for the fracture itself to heal. The gold standard today is the acid eccrisin splint. It's applied directly to the teeth, it stabilizes them, provides fixation, doesn't usually damage the gums, allows for decent oral hygiene, doesn't interfere with biting or other dental work, looks okay. And crucially, it can be designed to allow for non-rigid mobility, a tiny bit of flex, which is actually really important for PDL healing after luxations or avulsions. Or it can be made rigid for things like root fractures that need solid fixation.
So a little bit of movement can be good sometimes?
For certain injuries, yes. That non-rigid approach helps the PDL heal better. Older, more rigid techniques like arch bars are often avoided now because they can sometimes hinder healing or even encourage that external root resorption we talked about.
Wow. That's an incredible level of precision, especially considering how chaotic the initial accident usually is. It really highlights the complexity. Now, shifting gears slightly, when we talk about treating children, what's fundamentally different? Their mouths are still developing, their behavior. It must present unique challenges compared to adults.
Oh, it's an absolutely different ballgame.
Yeah.
And you're spot on. The biggest single difference, the thing that really dictates a lot of the treatment strategy, is the potential impact on the developing permanent tooth bud underneath the baby tooth. Plus, young children, as we said, poor coordination leads to more falls. Their pulp chambers are relatively large compared to the tooth size. And sometimes, yes, for very young or anxious kids, sedation or maybe some gentle restraint might be necessary just to provide treatment safely and effectively.
And the injuries themselves are different too, you said.
Yeah, the patterns differ. In baby teeth, displacement injuries, luxations, are actually more common than outright fractures. That's mostly because the bone surrounding primary teeth in kids is more elastic, more resilient. So the tooth and bone tend to move together rather than the tooth just snapping.
Right, the bone is softer.
Exactly. But the truly unique factor, the one that really keeps clinicians thinking, is that risk to the permanent tooth buds developing underneath. The roots of baby teeth sit sort of towards the cheek and biting surface relative to the permanent tooth germ below them. So the force from an injury to a baby tooth can get transmitted directly to that developing permanent tooth. It can interfere with its formation, its odontogenesis. This can lead to visible problems later when that permanent tooth finally erupts, things like enamel discoloration or maybe hypoplasia, an area where the enamel didn't form properly. It's like the injury to the baby tooth leaves a little mark on the permanent one's history.
Like a timestamp of the trauma. Wow, so how does that affect treatment choices for kids?
Well, it means treatment decisions are heavily weighed against potentially harming that permanent successor. Well, so for example, with crown fractures in kids, for simple enamel chips, maybe just smoothing, for enamel dentin fractures, calcium hydroxide liners, and composite restorations. If the pulps involve, specific pulpotomy or pulpectomy procedures are used, all trying to keep the baby tooth if possible without risking the permanent one. For luxations, subluxations are usually just monitored. Lateral or extrusive luxations might involve careful realignment or sometimes extraction if it's too damaged or poses a risk. And for intrusion, where the baby tooth is pushed up, it might be allowed to re-erupt naturally over, say, 4 to 6 weeks, but it will be removed if it looks like it's contacting the permanent tooth bud below or if any signs of infection appear. The prone tooth's health is paramount.
What an incredible journey we've taken. I mean, from the ancient practices, Hippocrates using rudimentary gold wire splints, all the way to today's highly specialized techniques. These advanced solutions, precise splinting protocols. It's clear the management of dental and alveolar fractures has just undergone this incredible evolution. We've really seen the critical importance of proper initial diagnosis, that incredibly timely intervention, especially for avulsions, and just careful, nuanced management throughout. And understanding these details, I think it really does empower you, the listener, whether it's just for your personal knowledge or maybe to help a loved one in an emergency or even simply to appreciate the immense complexity and, frankly, the dedication involved in modern dental medicine. Knowing these surprising facts transforms what seems like a common accident into this truly fascinating window into human ingenuity and, well, persistence. So thinking about this incredible evolution from that basic gold wire to protocols that can literally help revascularize and save completely dislodged teeth, what else might we discover about dental healing in the future? Things we might currently consider impossible. What kind of, I don't know, regeneration of lost tissue or maybe even non-invasive structural repair might be on the horizon that we can't even really imagine today? Makes you wonder, eh?